Tom Krivak, I'm going to call you out on a contradiction. You said, I'm a biomarker guy. But if the biomarker is negative, I'm going to use niraparib anyways. So I don't get it.
Well, it's predictive and prognostic. It's not perfect. And BRCA is a great biomarker, risk-reducing surgery. But do all BRCA patients respond to platinum-based chemotherapy? Is that 100%? I don't think so.
But we use it.
It's a biomarker. There's no doubt about it. So to me, I did read the abstract by Dr. Swisher, and how I looked at it is you have veliparib, which is not an approved part for ovarian cancer, and you have two groups that crossed unity. So you're comparing some things. So I'd love to see the slides of the presentation, but I think that, to me, I'm biased. I believe in biomarkers. Help me stratify to help develop my plan for sequencing, because I don't think we know how to sequence, because really that's what we're talking about. How do we sequence chemotherapy? And doing this for 25 years as a fellow, it seems like the best way to sequence chemotherapy is when you get in a larger group and they tell you have to do this. You got to go doxil, you go through your algorithms. But to me, I'm looking at HRD as a biomarker to help stratify, to help me develop a sequence. You're absolutely correct.
Tom Herzog, what do you think?
Well, I think you're seeing the difficulty that the experts have right now, because we don't have labels yet. We have a lot of new data. We have very different interpretations of these subgroup. And as I sit in these different panels, I see that. So there's I believe any information is going to be helpful. So I see the subgroup analysis where there's benefit. Therefore, I do want to use that. I think for me, I'm more information, the better. I think that these tests will evolve. They're not perfect, but I think they'll continue to get better. There's a number of tests in the works, and we'll see if we can do better in terms of not only being prognostic, but also being predictive as we move forward. But for me, I like these subgroup analysis. It's information we're otherwise not going to get. On the other hand, I do believe we have to be careful if in terms of regulatory, because if the intent to treat population and the primary population are positive, it gets a little dangerous to deny subgroups benefit and label. And so I have concerns about how these subgroups are being used, not only clinically, but also from a regulatory standpoint. So the quick answer for me, Brad, is yes, I'm going to continue to use HRD. I'm hoping for a better test. And it's great to have options, but I think this is an evolving dynamic.
Yeah, and I think what's most provocative in PALA, if you don't have an HRD signature, the hazard ratio is 1.00. So because those two therapies together have toxicity, financial and otherwise, I think you're on thin ice. I would never criticize you, but you're on thin ice if you say, look, I got a biomarker that says that the hazard ratio is 1.00, and I'm going to do both drugs together anyways. And if the label prevents you from using both drugs because of that reason, then I think it's going to be simple. I like flexibility too, but I really not sure that's the thing to do. So Sharon, if you have an HRD assay, and you and I talk to all of you all the time, you like the assay and so do I. If you are HRP, what's the best treatment for an HRP patient, a patient that doesn't have HRD, doesn't have somatic BRCA, doesn't have HRD? What's the best maintenance treatment for that? Because Tom Krivak says I got to do maintenance no matter what.
Well, that's a great question, and when you really look at these papers and think about it, in my mind, if a patient has HRP, that will either be someone that I observe or that I consider, giving bevacizumab to. But for me right now, with the data that we have, I would, really not push a PARP in that particular patient.
What do you think, Tom Krivak?
I think that's completely reasonable. That's how I look at it, because I do agree with the HRP. To give them two drugs together versus sequencing, you may get more long-term longevity, with having sequencing. I would like to say about the development of the HRD test, because I did read the abstract that looked at how they developed Myriad was to capture your BRCA patients. So in the abstract at the SGO, if you use 33, you captured 96% of the BRCA patients. When you use 42, you captured 92%. And the data that I looked at when they developed the 42 cutoff was capturing about 95% of their BRCA patients. So they took their BRCA patients and wanted to make sure that this HRD was capturing patients that look like that. When you look at the foundation test, the test was kind of looked at and cutoffs were made based off response. So you had the Myriad test that was developed looking at BRCA, then plugged into studies looking at responses, whereas foundation was developed and the cutoff was based off responses, not necessarily looking at the percentage of BRCA patients they missed that had a BRCA mutation. So I think the tests were developed a little bit differently. That's my understanding of how they did it and how Myriad has kind of made some of their cutoffs to try to capture those BRCA patients that are like BRCA patients.
Yeah, that's very insightful.